All right, tell us your story.
Okay, so we chose to look at responding to aggressive and violent behaviors that we've been experiencing an increase in over the past year and a half or so. Looking at our project setup, we took the E-QIP team, and they're comprised of multidisciplinary individuals from across the organization, and we did that so that we could represent various programs, individuals, and service areas in the effort to better understand the problem and to help develop those action plans to address that. All members of the E-QIP team had firsthand experience in either managing and responding to and/or investigating incidents of aggression and violence. So therefore, bringing experience along with expertise to the project and how we were going to move forward with this. In terms of the problem statement, what we recognized that, as I mentioned, we had an increased number of incidents of aggression and violence, and were resulting in post-incident outcomes that were not always favorable to all the individuals, so that being client, staff, service disruptions to other clients within the area that it was happening in, and potentially decreased morale as well. So we found that looking at our policies and our procedures and our emergency codes, that we didn't really have a standardized method in assessing and responding and managing. Obviously, we're using, clinical judgments and everything when we're addressing or we're encountered with this, but clear-cut steps as to how to respond and manage post-incident was needing some attention. So, looking at standardizing the process in order to provide staff with clarity and a concise method and how to engage while involved in this, and a standardized process for managing the incidents post-incident in an effort to strengthen our ability in providing that client-centered care and keeping risks at a minimum. So our aim statement was by March 31st, 2019, the organization will reduce the number of client behavior incidents due to aggression and or violence resulting in 911 assistance or code white by 50%. So, client behavior incidents with aggression or violence or, escalation are not uncommon in our area, but what we're looking to do is to manage those so that we can avoid 911 and or code white and manage that to increase the client satisfaction and make sure that we're addressing the needs of the client. In order to keep it manageable and to look at it, because we have multiple sites, so we have group living, our staff are out in the community, we have subsidized units out in the community, so we thought we would just look at it at 60 Bond Street, our main location, because out in the community it would look very different if you're involved in acts of aggression or violence. It would more than likely just go directly to a 911 assistance because they are out on the road and off-site. Also, we looked at regular hours as well. So this is our team. This is exactly how we look. I'm the one in the middle. So as you can see, we have multidisciplinary from across the organization. Next slide. So our story would be that over the past several years, the organization has seen an increase in the clients with complex needs. We're seeing increase in homelessness, chronic illnesses, and concurrent disorders of those individuals accessing services. As a result of the increase in the complexity of the individuals, we've begun to see increases in aggressive and or violent behavior incidents. To proactively mitigate potential negative impact from these incidents, we had already done some work in terms of an FMEA to identify the difficulties that can occur when providing services to hard-to-serve individuals. The goal of our E-QIP project is to reduce the impact of potential failure when responding to code white incidents and simultaneously maintaining safety for the client, staff, and visitors while trying to, again, meet with the client's immediate needs and ultimately not requiring third-party assistance. So in this one here, we can see our aim, again, to reduce that number of client behavior incidents and reduce that number by 50%. The reason we picked March 31st is because currently the data that we're collecting is through our incident reporting. So again, if our staff are encountering incidents and a client is aggressive and or violent, they use their clinical judgment, their skills, they de-escalate, and everything is fine and we move on. So in terms of collecting data that we currently had, we did that through incident reports that were completed because 911 or third-party assistance was required. Again, the changes in developmental testing and implementation, those are some of the items that we've looked at. So we have like a code mock white, mock assessment report. We're looking at reviewing our policies and emotional mapping, which we'll get a little further into. Our graphs of measures, again, we had to kind of go back. So although we're seeing an increase in the incidents, the raw numbers were small. But nonetheless, you can see that they are kind of increasing over time. So we just wanted to be, again, proactive, as with having done the FMEA and now looking at it. So this actually helps us to validate what we found in that. Barriers that we discovered were, there's environmental factors, the client complexity. We're also seeing a large number of unknown individuals accessing services for information, referral, short-term case management. So that adds another component or another layer to some of the barriers because we're not familiar with these individuals. In terms of assistance required from executive sponsors, continued support for the team to meet, the milestones, we have strong leadership that allows, ensures that the team is able to, have the time to work on the project during the regular work hours. And next steps for our project is analyzing results that we've come up through and effectively monitoring changes through the PDSA, and then sustainability and spread of those changes. Two sides of the same coin. So again, the problem statement that we came up with was, again, the increase in aggressive and or violent behaviors in the past year and a half. We recognize that clients have felt unheard and unsupported because we're not able to meet their immediate needs at the time of the incident. So very often we're dealing with de-escalating, but what is actually triggering them to be violent or aggressive? Usually there's a contributing factor to that. And when this occurs, all clients and staff in the building are affected by it. So again, our aim is to reduce that by 50% by the end of March. Next slide, please. So this was our first version in doing this. Now, when we were doing our project statement, I have to say we were challenged with the problem statement because initially we tended to be very solution focused. So it took us a few tries to get to it through some quality improvement tools that we did, and we did use several, and we'll get through addressing those. Next slide, please. So our first attempt at really honing in on this was to do a fishbone, and we actually did two originally, and then we had our third final version. So we identified the original problem statement needed to be revised to reflect the pain to the client. So again, we were being very solution focused, and we really had to hone in as to what is the pain to the client, and that became a recurring statement for us to go back to. How is this affecting the client? And we did identify multiple factors contributing to the problem, some being environment, process, clients, policies, people and staff, and barriers that we're faced with when addressing these incidents. Next slide, please. We also went through emotional mapping and experience-based co-design, which tends to be very effective. So what we did was we figured that if we took the emotional mapping and we applied it post-incident, we were able to see where the pain points were for the clients, for witnesses, and for the staff as well. So in doing this, what we did was we looked at incidents that had occurred. We asked people that were involved in those incidents if they would be willing to participate in emotional mapping. And it was very interesting when we collected all that back. Everyone was very favorable to participating. They all appreciated being validated through this use of the tool. So when we looked at the results across the three groups, individual surveys did show similar emotions at similar steps in the process. So we were able to hone in where, the challenges. There was inconsistency in the emotions post-incident. So we had, 50 felt positive, 50% felt negative post. So again, trying to go towards, 100% positive outcomes. Not always going to get 100%, but we'd like to increase that from a 50-50. We were able to recognize where there were gaps and inconsistencies. Again, participants were very positive in using the tool and reported that they felt validated after participating in this. They welcomed the opportunity to discuss the incident and provide recommendations for improvement. So, again, it was very, very positive. Strengthened the organization's commitment to experience-based co-design. So again, we're very committed to having the clients have a voice and participate in this, and let us know where we can improve, and validating how they feel. Improvements that we did from this, it was so effective and so well received that we're going to add this to our incident follow-up form. So for every incident that we have, the risk management department generates a follow-up form to get, feedback, group discussion on the incident if it's applicable to discuss with a group, recommendations, suggestions, and use this as a debriefing after an incident, not just for aggression and violence, but client behavior as a means to kind of allow those people that were affected by it or involved by it to share how they felt and have an opportunity to express that to us. And through this as well, we've developed new Code White mocks and evaluations. And Code White process, we discovered, was very hospital-based, and we need to take a look at that and really adapt it for community work that we do here. Next slide. So again, looking at the fishbone and the emotional mapping, we recognized three root causes. One was communication, so there being a lack of standardized messaging to the client that was involved in that behavior, such as, whether they're asked to leave or whether they're permitted to come back, or, just how we deliver that message and what that message is to a client that's involved. Communication breakdowns create confusion, client dissatisfaction, team splitting, siloed decision-making, complaints, and potentially a shift in culture as well. The next root cause was human and environmental factors. So we have that staff awareness and use of critical thinking tools and structured approaches to communication. So again, looking at strengthening that. We recognized our training requires updating, again, very hospital-based versus community-based. So how does that look? In an instance like this, we are calling 911 and support, as opposed to, a hospital that has a security team in place, and it can be very contained and not require a third party. And again, looking at the layout design of program areas, the time of day, how many staff are on the floor, should this happen, what are the areas like, and layout and design for, making sure that you remain safe and other individuals or witnesses in the area remain safe. And then thirdly, we recognized our policies and procedures were also contributing factors, so lack of a formalized process for the management of these incidents. So that's really referring more so to once the clinical work is done and you've de-escalated or you've called 911, what's the process afterwards? Do we have clear direction? Does the client remain at program? Does a client leave? Who makes that decision? What is the debriefing of that to ensure that all programs are aware of the incident and the outcomes? Because our clients are very much linked through various programs here because we're a hub model. So we could have an incident happen at day programming and the client has an appointment later in the day at our nurse practitioner-led clinic. How does that look? How do we manage that? Also, we thought that we should have interactive drills for emergency codes, not just a fire drill, but, for code white. How do we do that? Not necessarily how do we handle the incident, but what are the steps involved? Are staff well aware of who calls the code? Who, if you're calling 911, who meets 911? Who orchestrates, who leads, who follows through? Also aligning and cross-referencing our policies and procedures related to aggression and violence. So we have multiple policies that speak to aggression or incidents or managing and de-escalation, crisis intervention, and making sure that they are all cohesive and they all align. Reviewing current policies and procedures for the emergency codes, and then taking a look at our training to ensure it's not outdated. So any changes that we make, ensure that that training is there for onboarding, for new staff, and also as a refresher or annual training. Okay.
We're just working on it, but Moses has gone looking for cheese again. The next one is your charter, if you wanted to start.
Sure.
While we get it there.
So the next slide is our charter, and in comparison to our first version, it's quite completed. We were able to refine our problem statement to be accurate to what we were looking to do. We found that we had our measures in place, so our outcomes, so looking at the total number of client behavior, incidents due to aggression or violence, we were looking at that, and then as balancing measures, we would be looking at client satisfaction through annual surveys and through surveys that we have on a continuous basis. So we were able to look at that, and also our feedback process, a number of complaints and concerns for services received. So again, that would all be done and taken from, our emotional mapping, our incident follow-up, complaints that come in, and again, satisfaction that we monitor on a monthly basis. Again, we put down, we had now our root causes and some change ideas as well as the process measures to look at that. Next slide, please. Should I just continue, or?
Yeah, your next slide is PDSA.
Yeah.
On the mock code drill one.
Okay, so with our PDSA, what we were looking at was starting small and working from there. So we started with a mock code white drill. We hadn't had one prior, so we were looking at that, and we had predicted that in doing this we would have, excessive staff. Our predictions thought, we had identified poor communication during and post-incident, poor coordination of incidents, and at that time, a lack of leadership. So who took the role of decision-making during post, and probably resulting in confusion. Results included our mock drill. We actually just had that last week. And our next steps we would adapt, so we would be using our results to identify gaps and develop action plans. And then again, working in conjunction with run charts as well. In terms of developing and testing, our PDSA charts, or the ramp-up charts, so what we did was we had our code mock white. So again, we're looking at kind of looking at those results and then developing those processes. So again, it's very preliminary in what we're doing. Our emotional mapping, we had tested and tried it out, and we kind of looked at it, and now we're going to start implementing that into our incident follow-ups. And then again, our training, very preliminary in the sense that we're going to kind of take a look at everything that's happened here and then kind of review and revise our training. Next slide, please. Our run charts, as you can see, it was very quiet there initially. We had to kind of go really far back to get that data, but although the raw numbers are small, they do fluctuate. And when we take a look at this, you can actually see, you know, our busier times of the year. It gets quieter through the summer, up again, gets quiet. So it's very seasonal, again, as to when we're seeing people. So when we look at that through the risk management department, we can recognize those trends in relationship to the number of incidents that we're actually seeing at those times of the year. So it'll be interesting to see once we, you know, take a look at this and work further through our PDSAs and put some things in place as to whether we can actually see that difference that we're hoping to achieve by 50% by March. Next slide, please. Our driver diagram. So again, we had our aim, our primary drivers were to improve communication, increase awareness of the human and environmental factors, and to revise the policies around code white and aggression. Secondary drivers, we're looking at standardizing our communication. Again, it's not so much in that communication of de-escalating, but what is the messaging that we're giving the clients, the messaging to staff, to make sure that all the right people are aware, again, to ensure that we have or can avoid any siloed decision-making and everyone is aware of the outcomes during that, and increase that collaboration amongst the teams, again, because a client can very often be connected to 3 or 4 programs. Also improve our incident management at that time and a framework to assess those risks, and improve staff training and formalizing processes, you know, would greatly assist staff and that clarity in responding and guidelines for the staff. And then our change ideas that we have, we're looking at developing an incident response team would be one change idea to help us follow the pathways. EBD survey implemented on post-incident follow-up forms, standardized debriefing tool for the clients and staff, develop the interactive codes, develop a code white drill sheet, reestablish our crisis intervention training, update existing emergency codes, and include information regarding trauma and triggers. In terms of change ideas, so for our change ideas, what we would do is we'll include staff from across programs in a working group to review the policies, develop standardized methods for responding and managing incidents in order to strengthen the communication. In doing that, we would enhance the client and staff experience to achieve those positive outcomes. And then upon completion, we would have it reviewed by our client safety committee, our client family caregiver committee, again, that patient-centered care, as well as through our leadership. Our theory as a group, by developing a standardized method to respond and manage these incidents, the organization will strengthen its communication and again, enhance that client and staff experience to achieve positive outcomes, and implement the quality improvement tool, the emotional mapping that acts as a conduit for client and staff engagement in the development of experience-based co-design. And how will we know? We're going to continue to monitor our safety incidents to determine if there's been a decrease to reported incidents requiring those 911 calls or code white assistance. Data collection. So again, we're looking at that raw data that we collect through incident reporting, and our process measures will be those numbers of incidents due to that, client satisfaction on an annual and quarterly basis, staff satisfaction, and the number of incident follow-ups that have the emotional mapping recommendations, with balancing measures of client satisfaction again and the feedback process.
Next one.
Again, this is just our run chart to see where we're currently at, so it's just a more updated version. And I guess we can go to the next slide. Qualitative results. So to date, we're currently collecting that data by quarter. Again, the raw numbers are very small, so final data we will be reporting in March. Impact for results so far is for clinical outcomes, patient experience, efficiency, productivity, effectiveness, and economic analysis or cost effectiveness. In terms of overall challenges that we had with this, the initial scope of the problem statement, it was a very broad statement. It took several attempts to dig down, as I had mentioned earlier, and we really tried to focus on what was the pain for the client. Was, are they being heard at that time? Is there frustration for them, and that's causing the behavior? So if we're able to address that, we're able to minimize having to have 911 or code whites. Also, the other challenge we had in looking at this project was the incidents don't occur often in terms of 911 and code white. So therefore, piloting change has been a little bit slow to see if, with the emotional mapping and adding that, because we haven't had a lot of incidents. So again, that's why we have a longer timeline for it. So that was another challenge that we had. And it may be challenging to have clients involved in the incidents actually participate. Ideally, when you're looking at something or you're doing a review, you like to keep it fresh. We like to do our incident reporting within 24 hours. The same with the follow-up. We have a timeline on that. But again, so doing emotional mapping would be dependent on how a client is doing and their willingness to cooperate with that. So, it's very dependent on participation. So our next steps. So what we're looking at in sustaining our improvements is we'll be looking at staff education. Where we can, we will have processes embedded, standardizing processes where possible. And then, benefits from our learning, we're happy to share through community of practice or, other outlets that we're able to speak to, with other CMHAs or other organizations that are willing to or want to try, the emotional mapping and so on and so forth. So still a lot of work to do. As I said, we just had our mock last week, so we're still kind of looking at the findings. The group is going to continue to meet to kind of look at that as a group and review, come up with recommendations, and then move forward from there.
All right. Thank you, Rita. Are there any questions for Rita?
Hi there, it's Mike. And folks, please type your questions into that chat box and I can read them out. First of all, Rita, thanks for the work of your team on this. I was encouraged when we came and did the ideas session with your staff, just the level of support from leadership and senior leadership for quality improvement and to do it thoughtfully and well, and see that reflected in your project with your use of experience-based co-design and the emotions mapping. So very well done. A question I had is, have you thought about spread? You spoke about looking at the one location, the main location. Any thoughts on whether you'll be tackling or looking at next those who are remote or other locations, or even sharing within other agencies? Because I know there'd be other folks, I'm sure, who'd be interested in this learning.
Yes, we've actually had some interest with this. So what we would do is our hopes is to take on the main location again and standardize that. We do recognize that it's very different out in the community. So, you know, our group living would probably be handled in a different way. We also have our one project, our CREATE team, which offers 24/7 support. So how would that look? As well as those that are out in the community, we have our clinic, we have locations store to us, we have after hours and on-call. So these are all things that we'll look at once we get through this one. So yes, we do have it on the radar so that it's clear in any situation for staff what the steps are.
Great, and there's a couple of comments or questions here for you. The first one's from Alex. Alex is very impressed by your switch from problem focus to client focus, especially with your adoption of the emotional mapping as not only a diagnostic tool, but an ongoing feedback mechanism. Yeah, very cool. Also a comment here from Ivan. I think you've done a great work and to look at and review some of the background factors, environmental, such as time, day, physical area, possible precursors, etc., will go a long way to look forward, finding ways to mitigate the potential if you can identify some common trends or features.
Mm-hmm. Yeah, and that's exactly what we're hoping to do is, you know, to take a look at those contributing factors. It's usually not just something that's spontaneous. There's usually something that leads us to that. So, and we get a lot of that information now. We'll be able to get that through emotional mapping. So one of our questions is, how did you feel when you first got here? So right from that, we can see is there something that was going on prior? You know, were they not well? Were they challenged with something else? And that goes across the board for clients and staff.
Okay, can everyone hear me?